And welcome. My name is Dr. Riham Adil. I'm a specialist clinical pharmacist, and today we'll talk about ventilator associated pneumonia. So let's start our lecture for today. Ventilator associated pneumonia is defined as pneumonia that develops the patient receiving mechanical ventilation that occurs at least more than 2 days or more than 48 hours after intratracheal intubation. So what is a ventilator? Ventilator is a machine that is used to help patient breathe by giving oxygen through a tube placed in the patient's nose or mouth or a hole in front of the neck, which is called like a tracheostomy. And if the infection may occur by germs who enter that tube and get into the patient's lung. Mechanical ventilation have two classes. First, invasive ventilation, which is given through the endotracheal intubation or tracheostomy. So that's why it's called invasive mechanical ventilation. And the second, non-invasive ventilation, ventilatory support that is given without establishing endotracheal intubation or tracheostomy, which is called non-invasive mechanical ventilation. So why we use mechanical ventilators? Because it decreases the work of breathing until the patients improve enough to no longer need it and can take oxygen and give out carbon dioxide by himself without any support. What is the common and specific medical indications for mechanical ventilation? It includes surgical procedures, acute lung injury as acute respiratory distress syndrome or COVID-19, pneumonia, pulmonary hemorrhage, hypoxemia. Pathogenesis of ventilator-associated pneumonia as aspiration, contaminated secretions, contaminated respiratory equipment, and intubation procedure. Two classes of ventilator-associated pneumonia. First, we have early onset ventilator-associated pneumonia, which it occurs from day 1 to day 4, and it's commonly becomes from monotherapy antibiotics. Second, we have late onset ventilator-associated pneumonia, which occurs after 4 days, starting from day 5, and it's usually become multi-drug resistant. Ventilator-associated events, we have VAC, ventilator-associated conditions, which is more than 48 hours or more than 2 calendar days, or stable decreasing daily minimum, positive end expiratory pressure or fraction oxygen, followed by rise of PEEP, positive end expiratory pressure greater than 3 centimeter water, or rise of fraction greater than 20 points sustained from for greater than 2 days. Infection-related ventilator-associated complications, we add VAC, ventilator-associated conditions, plus temperature less than 36 degrees or fever more than 38 degrees, or leukocytes counts less than 4,000 or greater than 12,000 cells per millimeter cube, and one or more new antibiotics continued for more than 4 days within 2 days before or after ventilator-associated condition onset, excluding the first 2 days of mechanical ventilation. We have possible pneumonia and probable pneumonia. Possible pneumonia, which includes infection-related ventilator-associated complications plus sputum or bronchoalveolar lavage with greater than 25 neutrophils, or positive culture for pathogenic organism. Probable pneumonia, it will be the same infection-related ventilator-associated complications plus sputum or bronchoalveolar lavage with greater than 25 neutrophils and positive qualitative semi-quantitative culture for pathogenic organisms. How we can diagnose it? We have non-invasive sampling and invasive sampling. Non-invasive as sputum expectoration, blood cultures, and invasive bronchoscopic technique like bronchoalveolar lavage or protected specimen brush. Common causes of ventilator-associated pneumonia, we have gram-negative organism, gram-positive, and fungi. Gram-negative organism as Escherichia coli, Klebsiella pneumonia, Streptococcus pneumonia. Gram-positive organism as Staphylococcus aureus, Enterococcus, gram-positive bacilli, and finally fungi as Candida albicans, Aspergillus. We have two types of microorganisms: non-multidrug resistant pathogenesis and multidrug resistant pathogens. So, non-multidrug resistant pathogens like methicillin sensitive Staphylococcus aureus, Escherichia coli, Klebsiella pneumonia, Enterobacter species, while multidrug resistant pathogens as methicillin resistant Staphylococcus aureus or extended spectrum beta-lactamase, Legionella pneumophilia, or Aspergillus species. The risk factors for antimicrobial resistance in ventilator-associated pneumonia as prior intravenous antibiotic use within 90 days, acute respiratory distress syndrome preceding ventilator-associated pneumonia, septic shock at time of ventilator-associated pneumonia, acute renal replacement therapy prior to ventilator-associated pneumonia, and more than 5 days of hospitalization prior of occurrence of ventilator-associated pneumonia. So how can we treat it? If he already has all these risk factors or one of them, so it will be classified as multidrug resistant therapy. But if he didn't, so we need to check out first about the gram-negative bacilli. If we didn't have gram-negative bacilli, so we have to check about MRSA. If gram-negative bacilli and MRSA is negative, so we will give first as a monotherapy piperacillin tazobactam 4.5 gram intravenous per 6 hours, or cefepime as fourth generation cephalosporins 2 gram intravenous every 8 hours, or levofloxacin 750 milligram intravenous per 24 hours. But if he has no gram-negative bacilli, but he has MRSA, methicillin-resistant Staphylococcus aureus, so we will add on the previous monotherapy list, we can add vancomycin, loading dose 25 to 20 to 35 milligram per kilogram, and the maintenance dose will be 15 to 20 milligram per kilogram every 8 to 12 hours, or linezolid 600 milligram per 12 hours. If the patient has gram-negative bacilli but negative MRSA, so we will add piperacillin tazobactam or cefepime or impenem 500 milligram every 6 hours, or meropenem 1 gram every 8 hours. We will add to them amikacin 15 to 20 milligram per kilogram daily, or gentamicin 5 to 7 milligram per kilogram daily, topramycin 5 to 7 milligram per kilogram daily, or levofloxacin 750 milligram per 24 hours, ciprofloxacin 400 milligram per 8 hours, or azithromycin 2 gram per 8 hours. If the patient has gram-negative bacilli plus MRSA or multi-drug resistant, or has already the previous list of risk factors, so we will treat him as well by the following. We will add piperacillin tazobactam or cefepime or ceftazidime or impenem or meropenem or azithromycin to the second list: amikacin, gentamicin, topramycin, levofloxacin, ciprofloxacin, or azithromycin. Then we will add the third list for MRSA, vancomycin, or linezolid. So, as we know before, cystic fibrosis and bronchiectasis will be treated by double anti-pseudomonal antibiotics. We need to cover it by two different classes. And we need to check out if there is any alternatives other than using aminoglycosides or polymyxins, because both of them are nephrotoxic. Duration of therapy. The decision to discontinue the antibiotic therapy should be based upon clinical criteria: fever, cough, abnormal findings of lung examination. And although ventilator-associated pneumonia have traditionally been treated with longer duration of antimicrobial therapy, the new current guidelines recommend a 7-day course of antibiotic therapy for the treatment, where the authors of the updated guidelines didn't feel that longer duration of therapy were needed for patients with VAB infected with a non-glucose fermenting gram-negative rod, based on limitations of previous studies that recommended longer durations of treatment and data demonstrating that were no overall differences in either mortality or clinical cure with shorter courses of therapy. Additionally, shorter treatment courses decreases antibiotic exposure, antibiotic-related side effects, and the potential of antibiotic resistance. It's important to note that the guidelines we choose to be shorter or longer depending on the clinical situations that we already have, and radiologic and laboratory parameters. Ventilator bundle. We have peptic ulcer prophylaxis as proton pump inhibitors or H2RA, deep vein thrombosis prophylaxis as enoxaparin or heparin, daily sedation vacation and daily assessment for readiness to extubation, elevation of patient's head of bed to 30-45 degrees, and oral care with chlorhexidine 0.12%. What is the reasons for deterioration or non-resolution? It may be wrong organism, or wrong diagnosis, or complications as empyema or lung abscess. COVID-19 and ventilator-associated pneumonia. We already have found that a research about ventilator-associated pneumonia in critically ill patients with COVID-19 infections at European Respiratory Journal. And the most important that we noticed, it's talking about corticosteroids, interleukin-6 antagonists, and kinase inhibitors may further increase the risk of infection. Weaning and reinfection. Unsuccessful weaning has been associated with poorer outcomes. Elevated peak plateau pressure may increase the risk of unsuccessful weaning, whereas higher compliance and lower driving pressures may reduce the risk. Thank you so much for watching, and I hope you liked the lecture, and see you soon.